All right, everybody, let's get it kicked off here. Dr. Ben England, physical therapist, co-owner of Torrentia Medical Education, joined by CEO Grant Townsend of NuvoCell Biologics, as well as Dr. Raymond Butts, my other co-owner and chief research officer for Torrentia. So we're really excited to be here for another webinar. We're going to be covering cellular signaling pathways and tissue healing as they specifically pertain to exosomes. And we're really happy to be here. Thanks for joining me, guys.
Thanks for having us.
Likewise, happy to be here.
So, Grant, you are now newly certified as an orthobiological hacker. How does it feel surviving a weekend with us in sunny Miami?
I tell you what, the course I think exceeded all expectations. It was I know we had some of the team down there in Miami, like you said, and man, it was a ton of information, but extremely relatable, good information in the right context, and it's after going through it myself, I'm even more of a believer in Torrentia and then what you guys are doing now, and I think it's something that any provider can benefit from. So I'm excited. It was really good.
Thank you, Grant. That's
Awesome.
nice of you to say.
Ray, have you fully recovered from a 27-hour jam-packed weekend?
It usually takes me a solid 48 hours. But yeah, today's the first day I actually feel normal again.
Awesome.
I don't really know another way except to just, like leave it all out on the field sort of a thing. And so
Yep.
yeah, it's hard for me to, but yeah, it does take me some recovery time. Monday, I'm worthless.
All right, well, we're going to jump in now, talking about some of these cell signaling pathways. As providers, we know that we've got our typical three phases of healing: our inflammation phase, our tissue proliferation phase, as well as our tissue remodeling phase. At Torrentia, we sort of break that down a little bit further into our iris method, which is still a typical inflammation phase, an early proliferation phase, a late proliferation phase, and a tissue remodeling phase. And we really break that down because there's a critical point kind of in the center where, as you've got tissue proliferation happening, the earlier parts are very similar to the inflammatory phase. The later parts are starting to get into tissue maturation. So we subdivide those specifically as we talk about the different pathways. I'm going to start us off, Ray, in terms of what you know about the iris method and the tissue, pathways that we just mentioned. What are some of the cells that we know communicate, with all of these signaling pathways as they pertain to the inflammatory cascade?
Meaning the signals, or do you mean the
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 cells
cell?
themselves.
I mean, obviously the big one is the big one is mesenchymal stem cells, or any stem cells that are brought to the area. But then I think you have to remember that those same paracrine signals are also recognized by any sort of helper cells that are in the area too. Even so much as there's a lot of cells in the area that can actually receive signals to de-differentiate, and then they take on more of a stem cell role. So it really is a full gamut of cells that are all working together as a team to drive the repair. And those signals that are coming many, many different ways, which is, a lot of the things that we talk about on class, like they really are received by any cells that have receptors for them. And I would say that there's more of those cells than what we think.
Yeah, we also see our immune system cells as well, especially in the inflammatory cascade. And we know that some of the other progenitor cells, that these signaling pathways, we kind of take advantage of them to influence the healing cascade. Our cells such as like fibroblasts as well as our endothelial cells.
I think the
Um,
best example though is really the toll-like receptors, right? I mean, that kind of kicks everything off. I mean, as soon as you have an injury, you have damage, or you have and that can be in two forms, right? So you either have the patterning that is associated with that damage, or you literally have the guts of the cells that have been damaged, which become what are called PAMPs and DAMPs, which are fun to say because they rhyme. And they really provide information to the toll-like receptors, and depending on how many of them are present, meaning the quantity of them, they really beacon to the immune cells that you're talking about, specifically the macrophages. And that is a way that they can kind of signal cells that are even not in the area to come to the area in order to act. And you're right to say, that first phase, that immune phase, is not a phase that everybody enjoys, but is a phase which is really important to healing.
Yeah, and for those of you that aren't aware of some of the cell signaling pathways that we're referring to, I think it'd be best if we kind of just hit, kind of a high level overview of those signaling pathways. So we've got Ray's personal favorite, our AKT pathway.
I love when
We've
it's a
also
favorite.
got the MAPK or the ERK pathway, kind of tomato tomato. Our WNT or beta catenin pathway, the mTOR pathway, as well as our sonic hedgehog signaling pathways. So Ray, why are we interested in these pathways and what do they really do? Like, what's the overarching purpose of them?
So, I mean that's a broad question, but if I could really narrow it down to a single concise answer, we want transcription factors. We want to be able to control what is going on with the genetics of the cell, and we want to be able to orchestrate the repair, which we can do via replication of the DNA, transcription into RNA, and then translation of the messenger RNA into links of amino acids, which obviously you guys know are proteins. And the reason why that's important is, like I say in class, much like the tail wags the dog, the proteins that are made by the cell, which are really which we're able to essentially we can dictate, we can have an effect on with all of these internal signals and external signals. Those proteins really determine what the cell is going to do. Is it going to replicate and make more cells? Is it going to differentiate? And if it is going to differentiate, what type of cells is it going to differentiate into? Are they going to become skin cells, muscle cells? Are they going to become nerves? Whatever it is, I mean, at the end of the day, this big mystery of how do cells know? I mean, they know based on the proteins that come from that genetic material. And that's why it's so special, because those transcription factors in the world of regenerative medicine, that really is AP1 and NFK beta in the main. There are certainly others. I mean, those are the most well-known transcription factors that are associated with proliferation, differentiation, and cell migration, which obviously are the three most important elements of regenerative medicine.
Yeah, Grant, any big key takeaways with the cellular pathways from this weekend that pertain to the exosomes in particular before we jump into exosomal cellular signaling?
Yeah, Grant, if you could just give us a quick summary of the weekend.
A quick summary of the 27 hours. You got it. No, but to answer your question, I think that one of the key takeaways from me is one, how interconnected everything is. And then, I'm taking it at a higher level when we looked at all the different devices, whether it's orthobiologics or red light therapy or shockwave therapy, how those are all interconnected and influencing the same pathways was really fascinating to me and really made a lot of things click and why all these things work well together. And then, I think one of the biggest things, like you said, Raymond, the tail wags the dog is the proteins. It all comes down to the proteins, right? Transforming growth factor beta, influencing the AKT pathways, similar with vascular endothelial growth factors and how those can influence these different pathways is very critical. And I think it's really good. It was really good to get an understanding of that, to know how all these different modalities and how regenerative medicine really works on the cellular level.
In a rehab sort of way, I think it's important just to kind of pull everything together. I mean, the way that we really are able to have an impact on those pathways, among others, is both with both intrinsic and extrinsic signals, or another way of saying that is autocrine and paracrine signals. And it's really interesting. I mean, if you really look at all the different things that we're able to do in the world of rehab, and that includes exercise and loading, it includes all these different technologies, it includes manual therapy. I mean, how much we really are able to impact all of those signals, increase them, decrease them, whatever that may be, in order to truly be able to orchestrate and exaggerate these genetic changes that we're talking about. And that's, I think, you know, if there was one take-home message that I really want people to see through the orthobiological hacker course, it's really that, right? Like I, sometimes I think, oh wow, genetics is so complicated and like that's not in the realm of what we do, but really it is. I mean, that is the very impact that we're trying to have with all of these different ingredients that we're putting together into a bigger recipe. And it doesn't matter whether you're a physical therapist or a chiropractor, an acupuncturist, whatever that is. I mean, at the end of the day, I mean, that is really what we're after. And then everything kind of follows from there. And then just to and put something else that Ben said into context too, it's important to say that cells do talk to cells, and some of those signals are received by cells in that way, meaning that there are cells within the same tissue that kind of talk to new cells that are in the area, or, just with that local communication help to orchestrate that repair. And in the main, that's called the Wnt pathway. And even cells that are downstream, like somewhere else in the body, they can also signal and have an impact in the tissue where the repair is taking place. And that's what Ben was referring to as the sonic hedgehog pathway, which is fun to talk about because obviously that sounds just like the video game. And there's a very good reason for that because the guy who created that game was a nerdy microbiologist that now is very rich.
Yeah, most definitely. Well, as Ray had mentioned, this really does pertain quite, literally to rehabilitation, regardless of what profession you come from, because we know that many technologies, as well as many interventions, also influence those cellular pathways. Simply put, exercise and mechanical loading is an easy one. As Grant mentioned, red light therapy, photobiomodulation, high intensity, low intensity laser, really does influence those pathways. Shockwave, both radial and focused, have their different benefits in terms of influencing those pathways. Direct current technology, microcurrent, and other electrical modalities also act as signals. We can also influence those pathways, as we've mentioned, with products like NuvoCell and other biologic therapies. So it really is the same pathways that we're referring to. It's just a matter of when are we influencing them, why are we influencing them, and really the how we're influencing them. So Ray, do you want to talk about maybe a little bit with Shockwave, maybe just for example? We know Shockwave has, impact, on Wnt pathway, MAPK pathway, has profound impact on some of the peptides, that Grant mentioned, the tumor necrosis factor, TGF beta, as well as vascular-derived endothelial growth factor. Do you want to talk a little bit about maybe timing with Shockwave and some of these interventions?
Uh, yes, timing with respect to what?
Timing with respect to intervention, meaning are you going to want to do those pre, maybe involving some exosomes in your
Ah,
treatment or biologics,
understood.
during, after, let's just use Shockwave as an example of a technology that we might use to influence an exosome procedure.
Yeah, so I think that Shockwave really provides a couple of unique advantages. We know that Shockwave works primarily on mechanotransduction, which is very, very similar to dry needling. And in the main, there's really three different receptor types that we can have that sort of response, right? Integrins, we have mechanical sensitive calcium channels, and then we also have some of the purinergic receptors, the TRPV receptors, in which we're able to stimulate with that physical mechanical wave as it moves through the tissue. So what's interesting about that is that in each one of those examples, and each one is a little bit different, but at the end of the day, the stimulation of those receptors via that mechanical that wave that moves through the tissue, it really does increase or drive the cascade of events that we talked about before, either the ERK or the AKT pathway, which then brings us back to the same transcription factors. So, what's really interesting and what I try to show during class is kind of the synergy of all of those things, because at the end of the day, shockwave isn't just activating one of those receptors, it activates all of them at the same time, which kind of provides us a reinforcement. And then to take it one step further, after we get those transcription factors, the AP1 and the NFK beta, one of the things that is transcribed, as you said, is transforming growth factor beta, which then ends up providing a positive feedback loop to the very same pathways to ensure that they don't just get activated once, but they end up getting activated over and over and over again. And it's important to say that because one of the things that we also get with transforming growth factor beta is one of the most important elements of Shockwave, and that's angiogenesis, which is the reason why that particular technology is so powerful for bone, tenoosseous insertions, ligaments, really anything which really requires that additional blood flow or the creation of new vessels in order to be able to do the repair. That's where Shockwave shines. And then I think with respect to the exosomes, Shockwave really, I think it provides us an additional feature because I think that what we're going to see is that because it's this wave of energy that moves through the tissue that provides this mechanotransduction, we could essentially use that wave, if you can imagine like the analogy of a wave and a surfer, right? If the surfer on the surfboard is all of the exosomes, the idea is if we provide a lot of waves, can we drive the exosomes or the surfers deeper into the tissue where it really matters? So in that respect, it would really make sense to do the exosomes prior to shockwave and almost use the mechanical stimulation of the shockwave as a vehicle.
Awesome. Well, and if those of you on the call, if you're unfamiliar with, NuvoCell Biologics, what NuvoCell is, actually, you know what, Grant, I'll let you jump in real quick. Just give me your two sentence, what is NuvoCell and why did you create NuvoCell?
And just to set
Yeah,
Grant up for success, if I can, because I mean this will set the ball to him a little bit. I mean, of all those amazing things that I just said about transforming growth factor beta, remember, of course, that also drives in the main the connective tissue repair that needs to happen. So it does so many things, transforming growth factor beta, and it just so happens that of all of the amazing things that Grant is really talking about packaged into these exosomes is transforming growth factor beta. So it's almost like that is also providing the reinforcement in a different way of what we're really starting, if you think about it, with Shockwave. Go ahead, Grant. Sorry.
no, that's perfect. And what I'll do is I'll build off of that. So, we've been talking about different growth factor cytokines and exosomes. So obviously within exosomes, there's hundreds of different types of the growth factors and cytokines and microRNA and protein, transforming growth factor beta being one of those that we actually test for in our product. So what we've done with our product in NuvoCell is using the mechanism of that and exosomes being basically a natural delivery truck in the body that have characteristics and abilities to migrate towards damaged tissues. And we've encapsulated those exosomes in a lipid nanoparticle. And what that allows us to do is both stabilize the exosome at refrigerated and room temperatures and also help it penetrate the dermis so that we can formulate it into a topical cream, combine it with some transdermal drivers like DMSO, who many people are familiar with, so that we can apply this topically and drive these exosomes through the dermis, get them to release into the musculoskeletal structure where they can home to these damaged sites and deliver all of these different proteins that we're talking about that influence these different repair pathways.
I mean, if you really think about it, I think an interesting analogy. I mean, the more PM and R docs that I talk to, and I really do love to talk to them and ask them questions, like like they're excited mostly about PRP lysate. Like I would say to a physician, they will say that that is one of the big things of the future when it comes to regenerative medicine. And if you really think about what PRP lysate is, I mean, they kind of take all the platelets of PRP and they break them open and they take all of the amazing growth factors and proteins that you find on the inside and they concentrate them. And then instead of injecting the cells, which allow them to be released over time, they essentially inject the concentrated form of all of the goodness inside those cells, which is an interesting concept because it really provides patients with a much quicker relief and it's a much quicker response. And one of the big advantages of PRP lysate you get a concentrated form of transforming growth factor beta, which is not only important for repair, but it's also important in ensuring that the fibroblasts and the keratinocytes, which are the cells that are going to drive that repair, they do their job, but they don't work too much either, right? So they monitor to ensure that yes, they get the repair, but they don't start making fibrosis and scar tissue, which is what we don't want, right? So by doing it in a concentrated way like that with PRP lysate, it really is, according to the literature, starting to really show that it's advantageous. And if you think about it, what Grant is talking about with these exosomes and the cream, it's kind of another way of thinking about PRP lysate, right? I mean, really, he has everything packaged in these vesicles, which come directly from the stem cells, and he's providing it with a vehicle. But if you really think about it, it's kind of a backdoor way of us being able to do PRP lysate in the PT clinic or in the chiro clinic, and then mix it with some of these technologies to provide that vehicle. But in essence, it's really amazing to think about that maybe we could kind of live in that world a little bit too, in a way which is cheaper, a way that's more consistent, and a way which really fits within the bigger context multiple times a week of what we're doing with rehab.
Yeah, definitely. And Grant, one of the things that I like about it, most, and one of the things that excites me the most about using it in rehab is it's not just one concentrated dose. You guys talk a lot about protocols as opposed to just a single standalone treatment, especially in combination with advanced technologies. And I mean, on average, patients are getting 60, at least per protocol, treatments, roughly morning and evening, times
Yep.
30-ish
Yep.
days. They're getting 60 of those signals, and it sort of provides this in-between phase during rehab. And I think that's where we fall short many times, regardless of what medical profession you are, is patient compliance. What happens in between sessions, because, patients may come and see you 1 to 2 hours per week, but what are they doing the other 23 hours out of the day? What are they doing the other 5 days during the week? And it really gives them a way at home, to provide those signaling pathways to really aid and assist almost every phase of the recovery process and really continuously activate those pathways as Ray's been describing.
I mean, yeah, continuous. I mean, if you think about it, this is kind of the reason why, like even with needling, like we put the needles in, we leave them in the patient's body for a period of time, we continue to add electric. Why do we do it? We do it to continue to remind the cells and the tissue over and over and over again what it is that we want, what needs to be transcribed so that overall we get a more efficient repair. And what you're saying is exactly right. I mean, essentially, these exosomes are a way to continuously remind the tissue over and over and over again, with all of these different factors, like in between the treatment sessions, during the treatment sessions, in between the orthobiologics, so that, ultimately the tissue never forgets what it is that we want to achieve.
And Ray, what you're talking about there is dosing, right, appropriately in terms of whether you're talking about needling, whether you're talking about photobiomodulation, whether you're talking about shockwave, and really that's what we break down, and Grant, you got to see that firsthand, in the orthobiological hacker event, is really how we marry all of those together. Just as a teaser, Ray, and I can definitely kick us off, if you have a patient that comes in with, let's just say, osteoarthritis of the knee. Let's say nothing too crazy. It's mild to moderate, moderate to severe, something like that, where we would typically know that, exercise is good for those patients, but maybe they're having too much pain so that they're unable to exercise. We would do a lot of different interventions, whether we're talking about manual therapy, shockwave therapy, maybe some photobiomodulation to really try to bring down the inflammation and really start to influence the reparative process. When would we want to maybe start considering using some of those exosomes? I know you talked about application of exosome and then using shockwave. When should rehab providers really be thinking about using these exosomes with a patient such as someone who has osteoarthritis of the knee?
I mean, I think what you're asking me is it needs to be consistently. So, in other words, I think ultimately we're trying to continue to deliver these signals that are coming from the umbilical stem cells, just without the cells, do it within the context of the rehab treatment, but then also have the patients do it during the in-between time so that they're really bridging in between the treatments so that those signals are always there. They're continuously reminding the cells what they need to do. But I think in the bigger picture there, it's, figuring out based on how that patient presents, what it is that you're going to do, right? What signals you want to be able to impact. And then that's really going to determine at what point during the treatment that those exosomes need to be introduced. So if you're going to do shockwave, then yeah, I mean, those exosomes probably need to go on earlier during the treatment so that we could use it as a delivery mechanism. We have a patient which is a bit more ramped up, and they're more inflamed than what we would like, meaning now we have an environment of inflammation which is really it's really putting some of those stem cells and those reparative cells at risk. We got to tone it down, in which case now in which case now laser might be a really, really good tool. But if you think about what laser is doing and how we're stimulating cells differently, right, then it doesn't really make sense to do exosomes first. It makes sense to do the laser first. Why? Because if you think about what those exosomes are and how they're packaged, which, I mean, Grant can tell you way more about than I can, there is that lipid bilayer that is being used as the vesicle or the transport mechanism. Well, remember, any sort of fat is going to either absorbed or it's going to divert the light that we're trying to use during laser in a different direction, in which case it could really impede the laser beam from actually getting to the cells in order to have the desired effect on the mitochondria, right? So this is the reason why, like, it's important to have these conversations. It's important to know all of the different ingredients and not only how to do it, but what is the physiology that makes them work so that you could really make the correct choices to optimize the results that we're trying to achieve. Is that what you were asking me?
Hmm. Yeah.
Sometimes I
Yeah,
just
and just
answer
to
things.
and, and a quick comment on that too. I know one of the things we talked about this weekend, Ray, is like these different stages, right? Like we were just talking about. So, what stage is it appropriate to introduce NuvoCell? And I think one of the things that will be interesting to look into is what stage into the healing process that we've recruited stem cells to the area, right? Because ideally
Yeah.
we want that stage where stem cells are recruiting to the area, they're starting on their repair process, and then we want to arm them with all these proteins to keep them happy and keep them working, right?
That's right. And I think maybe where you're going with that, Ben, is there is a little bit of a delay during that inflammatory phase where you know you think inflammation, you think, oh, that's miserable to the patient, and they're in a lot of discomfort. And yes, you're right, but remember that a lot of those inflammatory signals really do provide extrinsic signals or communication to cells, which are really, really important as we're starting to bring stem cells to the area. And so some of these exosomes, if we're doing it too quickly, the idea is not to use them to disrupt that inflammatory phase, right? Ideally, it's really as the patient is coming out of that inflammatory phase, that's probably where the exosomes are going to shine.
Yeah, most
For the same
definitely.
reason as, like, you talk about peptides, right? Like, you read a lot of the literature, introducing peptides during that inflammatory phase, is really thought to be counterproductive because it may disrupt some of the goodness of that inflammation, if you will. But as soon as you're coming out of the inflammatory phase, that seems more like the sweet spot that, now we're really going to kind of orchestrate what happens from there.
Yeah, not to rekindle a conversation that's been pretty popular in at least rehab, athletic training, physical therapy, etc. Is after initial injury, do you ice or do you use heat? right? I mean, everyone has their opinion, but ice, while it may quickly calm things down and really get individuals sort of at a place where, okay, I feel good, the swelling's down, etc. That swelling process is the cascade of signaling factors that actually kick off the healing process. And many times we stifle those or delay those by doing the wrong intervention at the wrong time,
Yeah.
or even the right intervention, but just at the wrong time.
But shades of gray too, right? This is where it's important to understand what was the orthobiologic, right? And I'm sure, not to put Grant on the spot, but I definitely I like to make a very big deal, distinguishing between, let's say, a BMAC injection and an adipose dry stem cell injection and how patients typically feel afterwards, right? Because those are two very, very different things, right? I mean, I think Grant would tell you that an adipose dry stem cell injection is usually mixed with PRP ahead of time, right? That's just the normal way that they are prepared, which means that those patients are usually pretty miserable, meaning they have really a high level of inflammation right after the injection. A BMAC injection, on the other hand, is usually just a BMAC, right? It's not typically mixed with PRP, which means for those patients, they're a lot more comfortable, right? So in the case of adipose dry stem cells, those patients are miserable. In the case of BMAC, those are patients are kind of talking trash, like this is a joke. I don't feel very much at all. And if you think about it in that way, right, like then the exosomes could really be used for the adipose dry stem cells to kind of facilitate them moving through the excessive inflammation. Whereas in the case of BMAC, I think the story changes a little bit.
Yeah.
Yeah, yeah, I would agree.
So Grant, what's a big takeaway that you'd really think that providers should understand about exosomes? Maybe some common misconceptions, some misnomers. Ray mentioned cell-free. You may want to break down maybe a little bit what that means as people are thinking about this as a regenerative biologic.
Yeah, so the term cell-free essentially means without the stem cell, right? So the way stem cells work, as they migrate through the body, or even in a petri dish, right? They're secreting different extracellular vesicles. So the key word is extracellular vesicles, right? Because when you extract a stem cell from a sample, you're left with this acellular matrix, which are billions of different types of extracellular vesicles. Exosomes, which is what everyone talks about, they are the smallest and most abundant type of extracellular vesicles. And a key thing to note there too, and this is important if you're doing any type of injectables or using injectable exosomes, is a lot of people will tout exosome counts, and those it's actually impossible to validate exosome counts with the current instruments used, like a DLS nanoparticle counter, because they just measure the vesicle size. So, there's all these billions of different types of vesicles floating around in this matrix. And the DLS counter will measure the vesicle size, but it can't validate whether that's an exosome or not. Really, the way you validate if an exosome is an exosome is by protein concentration. So that's, this is why this kind of lends into the conversation and why we always like to talk about proteins, because at the end of the day, that's what's influencing the repair pathways. That's what the exosome is delivering, and that's what it's all about, in our opinion. So, I think those are the key things, is really understanding the difference between, extracellular vesicles, between, if you're looking at protein concentrations versus exosome counts, what really matters in terms of, therapeutic potential. Yeah, I would say those are some of the big ones.
So that's huge. I mean, just to walk that back a little bit. So in these exosomes, just to summarize what you said, not only are there extrinsic signals that really push the pathways that we talked about before to transcribe the proteins that essentially give those cells the instructions of what they need to do, but you're also delivering in those exosomes the very proteins. In other words, you're also delivering some of the proteins. In essence, they're pre-transcribed, which you're kind of starting at the finish line in some cases, right? So, at the end of the day, not only are you pushing the cells to make the proteins, you're also giving them the proteins that they're trying to make. which is particularly powerful, and doing in a way which is non-cell. And the reason why that's so important, just so that maybe this is an obvious thing, but for those of us that are non-physicians, we can't do cells, right? That's not in our scope of practice, but it becomes a very different thing to be able to use non-cell regenerative medicine, which is exactly what exosomes are.
Yeah, and I think the other big point there too is the timeline. Like you said, these proteins kind of circumvent that repair pathway timeline. So what that allows are quicker routes to recovery, right? Or quicker routes to reaction. And I know that's something we see pretty commonly on our side, right? We always recommend and advise providers like, hey, this is typically a very slow process. And in education, in the literature, like you talk about, Ray, these outcomes are measured over 6 months, 12 months, years, even, right? In like BMAC and adipose. But often I would say, very often with our providers, we see outcomes sometimes in days, sometimes in weeks, right? Very quick outcomes sometimes. And I think there's, two parts of that, right? It's the inflammation modulation, but also, I would have to believe some of these repair pathway kind of circumvention methods, right?
So, Grant, I mean, just to drive that point home, if you don't mind, would you mind to describe the case study that we talked about earlier today?
Yeah, definitely. So we're actually publishing this case study this week. We starting getting ready to go out, and this case study is from one of our providers who had a patient who suffered a torn bicep tendon and labrum. They surgically repaired it. 2 months, I believe it was 2 months after surgical repair, they retore the bicep tendon and retore the labrum. Did our MRI, confirmed it, was recommended to go back to surgery. Instead of going back to surgery, they did a 60-day protocol of NuvoCell, occupational therapy, chiropractic, and some massage therapy. I believe there were some NSAIDs in there as well. Within 60 days, it was essentially 95% recovery, 10 out of 10 pain to 0 out of 10 pain, 0 degrees out of 150 degrees scap mobility to 140 at 150 degrees. So significant findings, and then comparative when you look in the literature, and this is what I was sending you guys today. There's a systematic review out there showing similar pathology, a slap tear in athletes that try to avoid surgical remedies. And what the data showed out of 245 athletes is that one, 47%, only 47% of them returned to sport, right? Which is meaningful. And then two, the average time to return to sport was 5.2 to 5.7 months compared to 2 months that we saw in our case study. And obviously there's limitations to our case study. It's only one person. Right, but still significant findings nonetheless.
I mean, and I think another interesting way to think about the exosomes, I mean, what makes PRP so special, right? I mean, PRP is really a collection of concentrated platelets, and then normally PRP is leukocyte rich, which means that you also are going to get a lot of white blood cells with that too. And if you think about like what that really means, I mean, you're essentially doing that because we're using all of the cytokines and the interleukin factors that are going to come from those white blood cells as extrinsic signals. And if you look at what's going on in platelets, I mean, there's 7 amazing growth factors that you find in platelets that will slowly be released over time to provide additional extrinsic signals for those cells. And some of those growth factors, like platelet-derived growth factor, are specifically responsible for calling mesenchymal stem cells to the area, right? So, but if you think about that full package, which is available in PRP and why we're doing the PRP, every single one of those things that I just mentioned to you are found in exosomes in a non-cellular way. I mean, it's the ultimate backdoor non-cellular method that we can do within the context of physical therapy, right? In an additive way to what the physicians are doing with their orthobiologics, but in essence, it's delivering the same products that we're trying to deliver with PRP. Like if you think about it that way, that's super cool.
Yeah, I definitely think that it really begs the question. I was talking to an MD last week who was coming to one of our OBH courses later this year, and she was very interested in, why not surgery? Why not the conventional route? Why not just use conventional, even biologic, interventions? And my answer was simply efficiency. Like we look at studies on BMAC procedures and adipose-derived stem cell procedures, even with rehabilitation. And many of those studies, as we're finding out in 2024, 2025, even some that I've seen published in 26, the BMAC procedures, at least for knee osteoarthritis, I mean, patients are seeing outcomes, but they're seeing outcomes years later, not weeks, not months, years. And while those patients still are avoiding surgery, many of those patients, at least when it comes to pain, function, and disability, which are really the three things that matter to our patients, those three things still aren't any better in the weeks and months category, which is typically when our patients want to feel better. And the other benefit to that, besides conventional procedures, Grant, to your point, and also Ray to yours, is there's no downtime, right? There's no downtime in terms of, hey, you've got to sit out for 8 to 12 weeks. Maybe you're in a sling for the first six, with a slap tear, and then you're starting the rehab process, and then your return to sports somewhere around 4 to 5 months, about 50% of the time, if you get back to playing sports, at least according to the recent systematic review. So it's all about efficiency. People don't want to feel better. I mean, Ray, it's your your favorite phrase. People don't want to feel better now, or in a couple of months. They want to feel better this Friday.
Ye-
For sure.
Yeah, and I've got a lot of comments on that. You guys know my position, especially on the surgery side. That's kind of how I got into this space. But not only it's not only efficiency, it's also it's financial and patient burden as well. Like some of the stats out there around failed back surgery, right? Failed back surgery is the only failed surgery outcome that has its own medical diagnosis, failed back surgery syndrome. Like, well, first of all, that's just like, I can't even believe that's a reality. But two, when you start to look at some of the statistics, it's, there's stats out there showing that the Journal of American Medical Association estimates that we waste $10 billion a year on unnecessary spinal surgeries. I mean, it's just mind-boggling. And there's a lot of other statistics, showing failed back surgery rates upwards of 40%. My own failed back surgery is how I got into all this space. You guys know that story. But that's something I could talk on and on about. I'm very passionate about, obviously.
To go back to what you were talking about before, Ben, it's something else I wanted to mention that I've seen really good results, and I think much of the audience is probably, if they're doing anything at this point, I'd say they're probably all doing dry needling in some way, shape, or form, right? I I've seen particularly good results doing dry needling first, especially if you're going to treat like a tunnel osseous insertion and you're going to go in and we're going to cause a little bit of an inflammatory response, add a little bit of trauma, that sort of a thing, and then follow that with the exosomes, right? Like I that has been really cool from what I've seen, right? But I want you to think about what I just said, right? We're going to use the needle to go down, add a little bit more trauma, add a little bit of an inflammatory response, and then follow it with exosomes, which essentially are bringing all of the signals that would normally come from stem cells. I mean, if you think about that, that directly models the way that Regenex handles PRP. I mean, the normal protocol for Regenex is they typically do prolotherapy first.
Yep.
And if it's not Regenex, then usually they're sending patients to the clinic, to the PT clinic to do needling first because they want to have an inflammatory response maybe 3, 5 days in advance, like prep the tissue, if you will, and then they do the PRP with the understanding that the PRP is going to have a much better effect if you exaggerate the context in which the PRP is going to work. I mean, basically, what I just described with needling and exosomes is the same thing. It's just now we can do it all within the context of rehab, meaning chiropractic, physical therapy, whatever it is. But the pattern is the same.
No, that's great. Well, does anybody have any questions in terms of these cellular pathways? I know threw that up in the chat. We're on regenerative medicine, anything pertaining to technologies or exosomes. I know that we really unpacked a lot about what exosomes are, kind of in our first, episode, really unpacked what they are, how they work. So make sure you hop into the Torrentia tribe and go back and watch the replay. I think, Grant, it's also available on YouTube. Correct me if I'm wrong.
Yeah,
You can go back and watch that full hour webinar, really where we broke that down. Anyone have any questions? I think Cameron's being really, really, really quiet.
Maybe Cameron wants to ask something about cam kinase too. It seems like it's his favorite.
I'm learning. I'm sitting back learning.
I, we talk a lot about that in class because cam kinase 2 is one of the primary intrinsic signals that we can impact in a lot of what we do therapeutically, which it really has it has the same ability to activate those same cascades, the AKT and the ERK pathway. And as Cameron will tell you, cam kinase 2 provides what additional benefit related to repair?
putting you on the spot, Cam.
Definitely put me on the spot.
Cam kinase 2, it gives us added peripheral nitric
Nitric
oxide.
oxide.
It nailed it. And nitric oxide is one of the three main components that are required for angiogenesis.
Awesome.
There we go.
I got to know Cameron this weekend. Cameron's a great guy. Otherwise I would never joke like that. But
I'm learning. The class was amazing this weekend. I'm still processing it, seeing it in my sleep at night.
nightmares.
Well, I'm going to go ahead and just maybe turn it over to Grant for a second. Grant, how can people get involved with NuvoCell? I mean, obviously with Torrentia, it's pretty easy. You can go join the Torrentia tribe. If you're watching this from the Torrentia tribe, thank you for watching it in the Torrentia tribe. It's a free community of healthcare professionals, business owners, clinicians, doctors, physical therapists, athletic trainers, chiropractors, acupuncturists, and all the like, really helping each other kind of unpack biologics